Good morning, respected teachers and dignitaries on the dais and my colleagues. Anyway, I was given it has been a privilege to be invited back to SGPJ to speak about Tetralogy Fellow in front of my teachers. And it's been a humbling experience also to talk about how to do a tetralogy repair in front of the teachers who have already taught you. Anyway, the history of Tetralogy Fellow goes a very long way back. It's about 300 years since Mr. Stenson described the anatomy, and we have been doing repair since 80 years, the shunt procedure since 80 years, and the complete repair since past 70 years. And we have also inspired Hollywood to make a movie on it. And still, why do we need to still speak about Tetralogy Fellow? Are there any unanswered questions still? I hope so. It is yes. That is the reason I'm talking. Going back in the history, this is a paper which was presented in 1973. This speaks about the natural history of Tetralogy Fellow. In the paper, they had divided the children who presented with Tetralogy Fellow into various groups depending upon their symptomatology. With group 0, where they had no symptoms, where they behaved like a VSD, and group 4, where they had severe symptoms, who behaved like a Tetralogy Fellow with a pulmonary atresia group. Looking at the other table, where the focus is only on the children who were totally asymptomatic. There were 40 among the total group of 59. And with the time, at the first follow-up, at least by 6 months, nearly half of them had become symptomatic. And with time, obviously, the situation worsened. And even at the end of 1.5 years, there were 5 children who were lost, probably died because of the disease itself. And we can only imagine the condition when the children is already symptomatic at birth, the progress is even more faster. So why does this happen? The underlying pathophysiology of Tetralogy Fellow is there is significant undergrowth of the subpulmonary infundibular chamber. This eventually leads to progressive fibrosis, and there is consequently there is undergrowth of the pulmonary annulus and the arteries. So this is a progressive condition. Fortunately, a lot of studies has been done, and we have come up with guidelines to when to intervene on these children. The Indian guidelines presented through the IAP recommend complete repair for an asymptomatic or a stable or minimally sinus child between 6 to 12 months. Whereas most of the Western literature prefer to do a repair between 3 to 9 months. And we all agree that no repair should be delayed for more than 1 year of age. So what to do? Obviously, there is a lot, the surgical technique has already been refined. And nowadays, most of us prefer to do a trans-right atrial and a trans-pulmonary approach. I will just enumerate the few steps. We try to tackle the VSC and the infundibular stenosis through the transatrial route, the transatrial tricuspid route, where we evaluate and enlarge the pulmonary subvalvular area. And if we find the annulus is small or the valve quality is not good, we make an incision on the main pulmonary artery, look at the valve, release any supravalvular tethering, and do a commissurotomy. We assess the adequacy of the RVOT, which I'll talk about it in the next slide. And we then close the VSD and repair the supravalvular incision, which we have made with a patch. So how do we assess the adequacy of the pulmonary annulus? So we prefer to use a BSA related Z-score diameter values. And the target for us is to achieve a Z-score value of 0. And we sometimes accept a Z-score value of -1 or -2 when we are planning to do a valve sparing procedure. We should not use the term valve sparing procedure very loosely. I'm not talking about the procedure where we left one part of the valve thinking that it might provide some amount of competence. A valve sparing procedure should give reasonable amount of competence and have very minimal PR. Nowadays, we shouldn't accept any valve which is regurgitating for more than a moderate degree. And when we find the annulus is truly hypoplastic, we do a transannular incision. And the transannular incision, contradictory to classical teaching, we should not go berserk. We should limit the incision on the right ventricle and spare the infundibulum as possible. The target incision should accommodate the diameter, the required Hagar of the Z-score 0. Considering we are making the assessment in relaxed state, we should usually accommodate for more than 1 millimeter. Again, going back to history, this is a paper from NITO, which was famously known as the NITO criteria, where they had looked at their repaired patients, 104 among them, and they looked at the post-operative RV peak right ventricular to peak left ventricular pressure ratios. And none of the patient who had a ratio of more than 0.8 survived. So this was a cutoff criteria at that point. And so subsequently, considering the long-term benefits, we have come down. We have understood the good benefit is attained when the post-repair PRV-PLV ratio is around 0.5. Nowadays, we try to do an intraoperative echocardiography, and we try to find out the exact points of dynamic and fixed components of obstruction. And we try to relieve all fixed points of obstruction, whether it's at the annulus or the branch pulmonary arteries. And we should also note the degree of the pulmonary regurgitation which is present. Coming to the PR, it is an unavoidable consequence sometimes. And we know this, we already know the long-term complications of the pulmonary regurgitation. It has been said the RV dilatation, which results because of pulmonary regurgitation, predates RV dysfunction and which predates mortality. We initially thought the pulmonary regurgitation in the acute postoperative setting is tolerated well because of the thick RV, but this is also untrue. This is a paper from the Toronto group which shows where their comparison was done between a transcendental patch group and a non-TAP group. We know the children who had underwent a TAP group actually required a longer duration of ventilation and stayed in the ICU for a much longer time. And they also had a severe degree of PR, naturally. So what are the strategies we employ to prevent free PVR? There are a lot of reports which describe the use of monocusp valve, which was usually fashioned by an autologous pericardium or a PTFE membrane. People have also used partial part of the contigra to provide some amount of competence. The monocusp, this is a meta-analysis from 2022, and this is a table showing the duration of ventilation among these patients. Children who underwent TAP with a monocusp had a significantly lesser amount of ventilation period compared to children who underwent TAP without a monocusp. But we know the monocusp only lasts for a few amount of years, and eventually that also will give rise to free PR. So what is our technique at SGRH? We prefer to use a PTFE bileaflet valve, which we create intraoperatively. This technique has been described by Graham Nunn, and we have adapted. We presented our series in 2018, and we know that the operative time increases because it takes time to prepare the valve. But there's significant difference in the ICU stay compared to the child who underwent a valve procedure and a non-valve procedure. And we have been doing this, and our current experience is closer to 100 now. And still we have to come out with long-term results. However, not all patients with TOF are created equal. So what do you do for a child who is less than 3 months of age? So the usual options are a shunt or a repair. So we don't know the optimal management strategy. So the usual points towards a system to pulmonary artery shunt is we usually do it with a sternotomy, or some people try to do it to the thoracotomy. Nowadays, most of the places we do a modified BT shunt, although there are some scenarios where we'll have to do a central shunt because of significantly hypoplastic central pulmonary arteries. The shunt avoids a cardiopulmonary bypass and DSA altogether, and we all know the complications of a shunt. And the STS database, which studied between 2002 to 2007, the hazard function for mortality, the inflection point was the patient weight at 3 kg. But unfortunately, most of our patients come at the weight which is less than 3 kg, and we'll have to do a shunt, so making it a very high risk procedure. So what is the other alternative? So in 1991, the Boston people presented their early report on neonatal repair. But unfortunately, they had closer to 20% mortality. And when they went back to analyzing the data, they found children who had a Nakata index, children with pulmonary arteries which were of Nakata index less than 150 had the highest risk, and none of them survived. So they rethought the strategy, and they came up with other paper in 1999 with closer to 100 patients who were less than 3 months. Now this time they had 3% mortality, but the incidence of transcendental patch in their series were closer to was almost 85%. This data has been validated again subsequently by other centers also. So should we do a routine neonatal repair for all children presenting less than 3 months? So looking at the database, again, it is not universally accepted. The neonatal repairs still account only for 6% of all the TOF repairs which we have still done. So the experience is quite limited to very limited few centers. The argument for neonatal repair is when you do a neonatal repair, the effect of cyanosis on the brain development is usually curtailed. But to most of the centers, when they do a complete repair, they use DHCA, again, the risk of brain development is hampered. This is the database from the STS. And if you look at the risk mortality for the complete repair, just closer to 7.8% in the neonatal group. At the same time, the shunt also has a mortality of 6.2%. It's either one or the other. But waiting beyond just 1 month of age, the risk of mortality reduces to 2.5%. And we all know the best results come between 3 to 6 months or 3 to 12 months. This was a paper which came out in 2019. This was an administrative data set where they compared tetralogy of fallow repairs who underwent a primary repair and a two-stage repair. The red line representing the two-stage repair. After the initial steep fall, at the end of 2 years, only 84% of two-stage patients were alive, whereas on the primary repair, only 77% of the children were alive. Even though we quote a risk of 3% and 3 to 5% most of the papers, the long-term results are not actually good. So we have to understand repair tetralogy is a chronic disease state. And because there is higher incidence of TOF in this age group, there is always an associated complication which follow. So what should be the current strategy? Individualization of treatment should be the rational approach. For any child who is presenting with less than 3 months of age, he is definitely a challenging subset. At least in our practice, the relative indication for a shunt procedure is when we have significantly smaller pulmonary arteries. And if we have got anomalous ILD crossing the RVOT where we cannot do a transannular patch, and sometimes we do a shunt repair because of other reasons, and child might be having an intraventricular hemorrhage, preventing us to do a bypass procedure. The decision becomes very difficult when we have a threatened isolation of the branch pulmonary artery, where we have to subject a child to pulmonary bypass, cardiopulmonary bypass, and sometimes it is very difficult to manage a child with a shunt circulation rather than a complete repair. So it is always a balance between a surgeon preference and the unit experience. Coming to the last group, the children who present to beyond 1 year, the reason for presentation can be multifactorial. It can be socio-economic for most of the reasons. There is always a natural selection which happens in this age group, because we know 25% of the children who are TOF don't survive till the first year. Fortunately, most of them who survive have good anatomy and complete repair is usually possible. And the additional challenges are most of them have collaterals which need coil embolization in the preoperative period, or they have profound cyanosis. Sometimes they even present with cerebral abscess or stroke. This is the aim. This was the only paper which I could find from India. The AIMS experience shows 14% of all TOF repairs were done for teenagers and adults. And even among them, 16% required a two-stage repair, and 11% required coil embolization, and 70% still required a transannular patch. The usual complications are bleeding because of extensive collateral formation and venous engorgement, and pleural effusion because of a very thick RV, which we experience. So what should be the ideal repair strategy? This was presented by Dr. Charles Fraser in one of his innovative commentary. And I think we all should agree that we should always preserve the right ventricular function and be conservative in our transannular incision. And the treatment should always be individualized, and the patient follow-up should be for life. And it has to be, at least we should aim for 100% follow-up. Thank you.